and don't get started late.
Carrie, just one question. Can you also post the evaluation link towards the end?
Yes.
Because I'm on my iPad now, so I just realized it because I was going to post it, but I realized that I don't have the link on my iPad. I have it on my computer. So.
No problem. I've got it in email somewhere, Lori. So as soon as I'm done screen sharing for Dino, I'll be able to like pop into my email, grab it, and I'll post it towards the end. Happy to do that.
That'd be
and
great.
then for questions at the end, Dino or Lori, I don't know if you've talked about if you guys will verbally be asking Maria and Kimberly the questions, or should they look to the Q&A log themselves?
I think it's probably simplest if Dino, I can help out. I think primarily I'll leave it to Dino, but it's probably simpler that way, especially if Maria and Kim aren't as familiar with the Q&A function on Zoom. It's sometimes hard to, you feel a little overwhelmed. It's like trying to drink from a fire hose. So
yeah, sure. I know there could be lots of questions, so I'm happy for you guys just to put them out there and ask, and then we can try and answer them best we can.
I'll try to let you guys do your presentation and save the questions for the end, which would mean we might go over time depending on how many slides you guys will have. And if there's something really relevant, I'll interrupt and ask you the question in the middle of your presentations, if that's okay.
Yeah, sure.
And then I just had a note from last time, because last time I ended the session as soon as the Q&A was done, and someone had mentioned, you know, staying on for a little bit of a debrief. So if that's something you guys would like to do, I can't manually boot out all of the attendees if I don't end the meeting for everyone. So it might just take me a minute or two at the end to kind of kick people out, because they're used to having a webinar just end manually for them. But if I don't do that, we'll have to ask people to leave at the end. If you guys can make a verbal note, and then those that maybe walk away from their computers, I can manually boot them from the session. But it's just good practice to do that before you start talking about how did it go?
yeah, exactly.
Gotcha.
Yeah, so, they're usually, for the most part, people leave within, you know, a minute or so at the end. So we can, yeah. That's good.
So, okay, I think we're at 5:30. So if you guys are ready, I will start the webinar. You know, I'm just going to mute myself and turn my camera off. So I'm clicking around back here. I don't want to distract anyone. And I will just listen for your cues, Dino. Kimberly, yeah, as soon as Dino gives you that verbal cue on his last slide, then you can start to share and we'll go from there. Awesome.
Sounds good.
I'm going to mute myself.
Thanks, Carrie.
Good evening, everyone. Welcome to PCN Pain Rounds. I think this is maybe our fourth edition, and tonight's presentation is entitled A to Z's, Better Sleep with Chronic Pain, presented by KimberlyPhillips and Maria Fais. Just want to introduce our speakers tonight. KimberlyPhillips is a pharmacist with almost 15 years of experience. And since the fall of 2017, she's been working with the Calgary Foothills PCN Extended Health Team. The health team is an interdisciplinary team that supports complex patients with chronic pain and strives to help patients increase their function and activity, decrease stress, and learn self-management strategies to improve pain management. The extended health team has recently been piloting a new group on sleep and pain that's been very well received by participants. And Kim is very excited to be here today to speak to all of you on the role of medications in sleep, and particularly looking at non-pharmacologic ways to help patients with chronic pain get a good night's sleep. Maria Fais is a registered psychologist with a special interest in health psychology and chronic pain management, and joined the Calgary Foothills PCN Extended Health Team as a mental health consultant in January of 2016. Maria is also part of the One Step at a Time program, as well as a facilitator for population health group classes such as Craving Change, Happiness Basics, and Anxiety to Calm. As you've heard, the Extended Health Team is an interdisciplinary team that supports complex patients with pain and strives to help patients increase their function, activity, decrease stress, and learn self-management strategies to improve chronic pain. With that, I'd like to hand, oh, I have a couple other slides. I have a land acknowledgement. I really like doing the land acknowledgement because we're fulfilling our obligation to the calls of action of the TRC and honor those who are participating in the event across the province. And I'm sure you know that we share traditional and current lands of the many First Nations, Métis and Inuit, whose resilience and presence remind us of our treaty obligations and relationships. The province of Alberta includes territories in treaties 4, 6, 7, 8, and 10. They include a diverse array of culturally distinct Indigenous people whose histories, languages, and cultures enhance our communities and remind us of our ongoing relationships with each other, the land, and our own processes of reconciliation. A couple of logistics. We have a poll ready to see who's here today, and you'll see a link to an attendance survey in the chat box. That's how we'll take attendance and distribute CME credits. Otherwise, please use the Q&A function to ask questions. Remember that the chat is open. However, the Q&A function is where we would like you to enter questions, just easier for us to keep track of questions. We'll try to save the questions for the end, but if there's a particularly relevant question, we will endeavor to answer it in real time. The learning objectives tonight include answering common patient questions about the role of medications in sleep management. We'll take some initial steps in a CBT-based sleep treatment plan for a person with pain and offer affordable and accessible resources to address ongoing sleep problems. Only disclosure is that the program, our program receives in-kind support from the Alberta College of Family Physicians in the form of webinar infrastructure, so thank you. A bit of background about these pain rounds. They're open to anyone, but designed primarily for PCN or primary care teams. They recur 6 times a year with the focus on chronic pain and issues common to people with pain. We try to rotate the weekdays to allow folks to join us if one day is particularly busy for others. We find that rotating the days is most amenable to having most people attend. And we'd really, really, really appreciate it if you give your feedback via the link in the chat when you receive our evaluation in an email this week. Our planning committee, this is a crack team. They're awesome. You probably recognize some of the names here. I want to particularly thank Lori Montgomery for championing primary care and particularly chronic pain management in people's medical neighborhood and medical home. Thanks everyone though for taking their time to help plan these offerings. And we'll plug our upcoming round in June with Kara Irwin, who, if you've ever heard speak, is fantastic. And she'll be talking about management of trauma in people with pain, which, as you probably know, is pretty common. Just going to go back to another screen here and get our slides up. Can we see the slides? Are they shared? They're coming. Here we go. Voila. Without further ado, Kim and Maria, thank you.
So hello, everybody. Maria and I are very happy to be here tonight to talk to you about better sleep with chronic pain. As a pharmacist, I'm going to be covering the medication portion of it. And then Maria's going to be talking more to you about CBTI, as well as about sleep itself and chronic pain. So the first thing we're just going to talk about is, what are those most common medications that we're using to treat insomnia? And those, of course, would be our benzodiazepines and Z drugs. You'll see that I listed a long list of benzodiazepines there, but actually lots of them don't have official indications for sleep. Some of them are used for anxiety and other things. We're going to be talking about this group as a whole today, but for the use in insomnia only. And then we're also going to be talking about Z drugs. So I've actually listed 3 Z drugs there, zolpidem and zolpidem. You'll probably be very familiar with. Zolpidem is actually a newer one that's just kind of come to the Canadian market. It is very similar to zolpidem, has similar side effects, similar effects overall, and it will be more expensive than zolpidem because it's new to the market as well. So let's talk a little bit about some of those common myths about sleeping pills. So the first one I've listed here tonight is that sleeping pills are meant to be used long-term, example for greater than 4 weeks. And by looking at our patients' use, we would think that that would be true. But it is a myth because all medications approved for treating insomnia in Canada are to be used typically for 2 weeks or less and no longer than 4 weeks. And I actually looked up zolpidem's monograph just for this presentation, and it actually recommends that treatment should generally not exceed 7 to 10 days. Myth number 2, sleeping pills help patients to feel more rested in the morning. So one of the interesting things about benzodiazepines and sedatives in general is that they have significant adverse effects on our sleep structure. So they decrease our REM and our delta sleep. And delta sleep is our stage 3 and 4 of our sleep cycle. And this is what is considered to be our deep sleep. And this is what helps us to feel rested in the morning. So though all patients might get a little bit more sleep, we actually think that it might not be that deep sleep that they need to feel rested. And then my last myth there is that medication is the best option to treat insomnia. And we're hoping tonight, after our talk, we're going to convince you that CBTI should be that first-line treatment for insomnia in Canada. So are sleeping pills really worth it? I think this is a really neat slide to kind of show your patients. It comes from the Canadian Deprescribing Network. And it shows the benefits is that 1 person out of 13 will experience one of the benefits below. And the benefits are extra sleep of about 35 minutes and getting to sleep faster of about 14 minutes. So the benefits by any means aren't huge. And we know that it affects the sleep structure too. Now, what are the harms? 1 person out of every 6 people will be harmed. And this includes a delayed reaction time and impaired cognition, 50% increase in falls, and a 2 times increase in hip fractures. They also have a driving equivalent to a blood alcohol level of 0.06 to 0.11%. That was kind of a new stat for me. I hadn't seen that before, but they've done some studies, especially with zolpidem, that showed that even 11 hours after taking that medication, that their reaction time is delayed and they would be considered impaired. And that's what makes them more likely to get into a motor vehicle accident. So when we kind of compare those benefits versus the harms, you can kind of see where those harms are really starting to outweigh the benefits. And it's more likely that you're going to be harming a patient than you're going to be benefiting a patient if you go to treat them with these types of medications. There are other harms, so some of those ones I've repeated, but there is also tolerance building. So with those benefits of, the extra 30 minutes of sleep at night, you're going to find that over time that those benefits are going to wear off and they're going to have tolerance that builds to the medication. It's just not going to be as effective as it once was. There's also a lot of drug interactions that can happen with these medications. I think it's important to note that, especially in our chronic pain patients, that they're already taking a lot of medications that might be sedating, that cause CNS depression. And we got to watch about how much extra sedating medications that we're putting on top. And then the other thing is that benzos really increase your risk of mortality and hospitalization when they're combined with opioids. And you might also be having those chronic pain patients that are still on opioids as well. The last thing that I have on that list is dependence and withdrawal symptoms. And I think this is really important to talk about because people will become physically dependent on these medications and they may have trouble getting off of them. So what are those withdrawal symptoms? So rebound, insomnia, anxiety, irritability, sweating, and GI symptoms. And I think it's really important to talk about this rebound insomnia. Because what happens when patients start taking a sleeping pill is that they might find some temporary benefit, that their sleep feels a little bit better because they're falling asleep just a little bit quicker. But over time, that nightly use is going to be associated with a gradual loss of effect. And so what might happen is they might choose to increase their dose, and that same tolerance will build. And then they might choose to try and stop their pills on their own. And what happens is you get this rebound insomnia, you've got this anxiety, and it feeds the belief that they need that medication to go to sleep. So it's really important that patients know that they become physically dependent on them, and that usually we might need to taper these medications to help them get back off of them. Now, what about other medications used off-label for sleep? So we know that we'll try lots of different things to help patients sleep. We've got tricyclic antidepressants. We've got antidepressants like trazodone and mirtazapine. There's also antipsychotics, and I hope everybody knows by now not to be prescribing these ones primarily for sleep. And then we've got our sedating anticonvulsants like pregabalin and gabapentin. And the really important thing to note here is that there's very limited evidence for the use of these medications in patients. But what we do know that all of these medications do also have significant side effects as well. So when we look at the side effects for something like a tricyclic antidepressant like amitriptyline, we know it's very highly anticholinergic. So it can also cause memory impairment. It can cause dizziness, falls, plus all the things like dry mouth, constipation, dry eyes. So it comes with significant side effects, but we don't know what the benefits, if there are any, for actual sleep. I know that trazodone is another favorite one on the list that people will often prescribe for primarily insomnia. And once again, there haven't been any objective studies that allow for clear-cut evidence to recommend this primarily for sleep. And it does have side effects too. So next day sedation can be a problem for patients. This can often be worse in elderly patients where they tend to get a bit of a longer half-life. It can also cause orthostatic hypotension and priapism as well. Other things on the list, yeah, you all know the side effects with the antipsychotics and the anticonvulsants. So really the purpose of going through these is just to remind you that we don't have the evidence to say that these are good medications for sleep, but we do know that they have side effects. Now for our chronic pain patients, we might need to use these medications anyways. You might be using them for neuropathic pain, you might be using them for depression. And so you can tailor these medications in patients for those conditions who might also be having trouble with sleeping. But I'd really try to not to use them primarily for that diagnosis of insomnia alone. And just on that list, I'll note that there is one medication on there that does have an official indication for sleep maintenance, and that's doxepin. And that's at a 3 to 6 milligram dose. Doxepin tends to be very highly anticholinergic. They think less so at that lower dose, but I would still be cautious about using it in elderly patients. So what about OTC and herbal supplements? So we know that this is something that often our patients are going to try. They're going to try the stuff they can find off the shelves in the pharmacy. And so for those sleeping pills that you find over the counter, usually what they contain are antihistamines. So things like diphenhydramine, doxylamine, and tolerance to their sedation usually occurs within about 3 to 4 days of continuous use. So you start using it and within a couple of days, you're not going to really find it's that effective. And they are very anticholinergic once again. So they've got lots of side effects. And so we really caution people not to use these medications, especially if they're older. For herbal medications like valerian, kava, passion flower, for the most part, I just don't have evidence to tell you to use them. And there is always the possibility with drug interactions. Now, melatonin actually seems to be a bit of a reasonable option in terms of safety. For the most part, minimal effects. We're unsure on the clinical significance, but there does seem to be a bit of clinical evidence for use in people with jet lag, delayed phase sleep disorder. They do have the potential for some drug interactions. So I always say if patients want to take melatonin, they should just check with their community pharmacist, make sure it's not interacting with something that they're already taking. And so if they want to try it, I think it's a fair enough thing that they can try. Usually we try a dose of about 1 to 3 milligrams, and they can try that even taking a couple hours before bed. It sometimes makes it a little bit more effective, up to a max dose of 5 milligrams, and to give it a trial about 3 weeks to kind of see if it's working. If it's not, then the patient can stop it. And then the last one I put on here was L-tryptophan, which is sometimes something that we'll see prescribed for patients as well. It's actually an essential amino acid that's found in many proteins such as red meat, poultry, eggs, dairy products. It does have a little bit of preliminary clinical research showing that it might have some benefits for sleep. The important thing to remember, though, it is a precursor to serotonin. So combining it with other serotonergic drugs might actually increase your risk of serotonin syndrome. And once again, I caution in our chronic pain patients, it's fairly common that they might be on antidepressants for depression, for pain. They could be on other serotonergic medications like muscle relaxants, as well as sometimes things like opioids. And so I just worry about putting up too much serotonin. If patients really want to sort of get the benefit of L-tryptophan, I'll often suggest that they try something like a half cup of yogurt before bed to get some of that natural source of tryptophan from our food. So the next thing I wanted to sort of cover is what other medications or substances can contribute to insomnia. If a patient comes to having trouble sleeping, I always suggest you do a quick look over their medications to see if there's something that might actually be affecting their sleep. Sometimes it's as simple as changing the timing of that medication. So making sure that they're taking their diuretics early in the day, things like their corticosteroids early in the day. Sometimes I find people taking certain antidepressants later in the day, and that can be interfering with their sleep. Duloxetine is often one that can cause some insomnia. So sometimes switching from bedtime to morning can help make a difference for that. And then other things on this list are things like alcohol and caffeine. So alcohol is something that sometimes makes people feel a little bit sleepy, but once again, it does interfere with sleep structure. So they're unlikely to get as good of a deep sleep. And then caffeine is important to remember to talk to your patients about. It does have a fairly long half-life. In elderly patients, it can last 8 to 14 hours. So usually what we suggest is that you try to have your last caffeinated beverage before noon. And to remember that caffeine can be in a variety of foods, drinks, it can be in medication and many herbal supplements. So just looking for other sources of caffeine as well. So I've kind of told you a lot about the harms of sleeping pills and why not to prescribe them. And you might be saying, well, what do I choose then for a patient who comes to me for insomnia? So I turn to Choosing Wisely Canada to get a little bit of guidance here. And they have two statements that I thought were really well fitted for this presentation tonight. And the first one was, don't routinely prescribe benzodiazepines or other sedative hypnotics for promotion of sleep without first a trial of non-pharmacologic interventions. And two, don't prescribe or dispense benzodiazepines without building a discontinuation strategy into the patient's treatment plan. So I think those are some words of wisdom for us there. And so what I'm going to highlight is what to choose. Well, CBTI really should be our first line intervention for patients with insomnia. Changing sleep habits, relaxation techniques, sleep restriction, and cognitive behavioral therapy for insomnia are preferred and more effective than medications, and they're not going to cause your patients any harm. Now, that being said, I know there might be situations where you think, oh, maybe I do need to give this someone a sedative to help. And what I suggest for that is try not to if you can, and to really reserve those medications for situations where poor quality sleep is negatively impacting daytime functioning. And if you are prescribing it, to use the lowest effective dose for short term. So ideally keeping those prescriptions less than 2 weeks to keep them off of it. And if you have patients that are on sedatives, to sort of reevaluate their use for efficacy and potential harm, and to try and taper and discontinue gradually if you can. And for anybody that you're giving a sleeping pill to, you should be talking to them about CBTI and using those strategies in conjunction if you're using a sleeping pill. Now, for many of us, we might already have patients that are already on the sleeping pills. And you might wonder, well, how do I get that conversation started? And so the first thing that I'm going to say is be curious. Ask about your patient's sleep. Are they having trouble falling asleep? Are they having trouble staying asleep? Have they noticed that they're not sleeping as well as they had been before when they first started that sleeping pill? Do they have any concerns about their sleeping medication? Do they complain of feeling fatigued or groggy in the morning? Have they had some falls? Do they have concerns about their memory? Review the potential benefits and harms of the medication. Note to your patient that the benefits are very small and that they were never intended to be on these medications long term. Discuss using CBTI as a safe alternative to help with sleep. And review the benefits of stopping the sleeping pill. So let your patients know that they can expect improved alertness and cognition. They'll have reduced daytime sedation, reduced falls, and less reliance on medications. And discuss if they would be willing to try a slow taper of their medication. It is important that if you're asking a patient about coming off their sleeping pills, that you ask them if they've tried it before, because it could be that they may have also had that rebound insomnia, which drives the thought that, yes, I need a medication to help me sleep. And then the last thing to do is, even if your patient isn't ready to start that taper today, provide patient with resources on deprescribing sleeping medication and sleep CBTI, because often what we're doing is we're planting that seed, and they might come back to you next time and say, hey, I've thought about what you said, and I think I'm ready to try making a change. And then the last thing I thought I'd do is just a quick example of how do we taper a patient off of a sedative medication. And I'll be honest, there isn't a magic formula for that. It's going to take time. The most important thing is to make sure that your patient is ready and willing to make those changes to their sleeping pill. Go low and slow with dose reductions. Usually, the longer a patient has been on a sleeping pill, the longer it will take to take them off. In the past, we have done some switches where if someone was on a short-acting benzodiazepine, we would switch them to a long-acting one. But for the most part, this hasn't really been shown to be more effective. So usually we just try to reduce the dose of the medication that they're already taking. And it can be helpful to give the patient some control over how quickly they're reducing or by how much. And you can use a combo of reduction in dose as well as drug-free days to help that patient get off of the medication. As I said, it's going to take time, weeks to months, to get off of it. It's important that you have a plan for follow-up and support. And so I often suggest that a patient make a plan if they're going to be unable to sleep. And so they might have a good book ready, they might have crossword puzzles, sort of normalize the thought that they're going to have a little bit more trouble sleeping at first, but over the long run, they can expect to have better sleep. And it's really important for you to continue to have regular contact or have someone on your team have regular contact with that patient to provide them with additional support and encouragement as well. And once again, use that CBTI in conjunction with tapering. One of the things that I think can be helpful is doing a little bit of sleep restriction. So often what you can suggest is tell the patient to try waking up 30 minutes earlier on the day when they're starting a taper to help build that sleep drive for that night, to make it just that little bit much more easier to make them fall asleep. So I have a few different resources that I wanted to share with you guys. These are some of my favorites. So the first one is deprescribing.org. Many of you might already be familiar with this one. And this one has both guidelines and algorithms for the healthcare professional as well as for the patient. And they are just so patient friendly, so clinician friendly. So I really suggest you give these ones a look. And then part of their website as well contains these, what they call empower brochures. And they're designed for patients to provide them with information about certain types of risky medications, including benzodiazepines and sedatives. And it really challenges some of the preconceived beliefs that they might have of them and empowers them to take some action. They also provide patients with some sample tapers for trying to get off some of these medications too. They also have lots of patient stories in there that just makes it a little bit more realistic and manageable for the patient to attempt something like this. And then my last favorite one is mysleepwell.ca, and I recommend this for every patient who is having trouble sleeping. It is a patient-focused website, and it focuses on how to get a good night's sleep without medication. It does a really great job of reviewing the dangers and potential harms of sleeping pills. And it provides a ton of info on using CBTI as an effective, non-harmful way to manage insomnia. And it's got a ton of lists of resources and apps and things that patients can use to kind of put that CBTI into action. Also has things like sleep logs and sleep tapers as well. So those are some of my favorites. So my take home tonight about sleeping pills is that for most patients, the potential harms of sleeping pills will outweigh the benefits. We suggest to reserve using off-label sleeping medication for when insomnia is associated with a comorbid condition such as pain or depression. So for example, saving that amitriptyline for also using to treat their neuropathic pain. We also suggest for patients already using sleeping pills to discuss the potential harms of the medication and the benefits of discontinuing the medication. Talk to them about CBTI and letting them know that getting off sleeping pills will take time and support. And with that, I'm going to let Maria talk to you more about chronic pain and sleep, as well as CBTI.
Maria, before you start, Maria, can I just have a couple questions
Okay.
from participants for Kimberly. Thanks, Kim. That was amazing, and a good reminder. I sit here in shame, knowing that this is hard work, and always good to sort of bone up on how important this is and how to manage. But Kathy Scrimshaw has a question about. Well, she asks, is there any indication for use of CBTI or medication for sleep in colleagues with shift work and switching from day to night?
And I don't know the exact answer to that. Maria, do you know more about that? I know you really looked into the research on CBTI.
Well, those could be considered precipitating factors, right? When you have a change in your life and you are, your sleep schedule is different, right? So it will require, you can try, I think it will require some time, right? And some work on readjusting that sleep schedule. In my personal practice, I have found that patients that told me, hey, I work shift work for many years, I noticed that yes, their sleep patterns have changed a little bit as a consequence of doing that work. So I'm not sure how much the impact will be. I think it's worth trying, and every person is an individual, so many people may find different benefit to trying, but I don't think there is any harm in trying.
Thanks, both of you. One more question before I let Maria start. Lorraine asks, how long does rebound insomnia last?
And so I don't have an exact timeline for that. I kind of think it can be a few days to a few weeks, and it might just depend on how, and probably a few days to a week would probably be the better answer for that. That it's not going to last too long, but they have to be able to be okay with having a little bit less sleep at first to improve it with the long term. So a few days to a week is probably what I'd say.
Thanks.
All right, so I'm gonna start by connecting the dots a little bit between chronic pain and chronic sleep concerns. So we know that a great number of patients with chronic pain will also experience sleep difficulties, and insomnia is actually one of the most prevalent and distressing and persistent concerns associated with chronic pain. The interesting thing is that pain, the relationship between chronic pain and insomnia can be bidirectional. By that, I mean that, yes, pain can prevent people from falling asleep as fast as they would like. It may interrupt their sleep at night, but also the lack of sleep can do a number on their pain, can generate more pain, lower their pain threshold. So they go hand in hand, unfortunately. Next slide. Thank you. Okay, so there is also something interesting that has been found. Patients with chronic pain tend to catastrophize about their pain. By that, I mean patterns of thinking and behavior associated with actual pain or the expectation of pain. For example, somebody with chronic pain may often think, oh, my pain prevents me from doing the activities that are important to me. I can't do anything because I have chronic pain. Or they may avoid activities because they have fear of experiencing pain. or they may, imagine a bleak future because they have chronic pain. So this tendency to catastrophize about their chronic pain also plays a role in their sleep. And actually there is interesting research saying that pain catastrophizing also impacts sleep and has been correlated with decreased slow wave sleep. So they get a less deep sleep. In patients with fibromyalgia, it's very common to find that they have non-restorative sleep. Next slide. Okay, so we know that physical, emotional, and cognitive factors influence the sleep concerns experienced by people with chronic health conditions and chronic pain. And actually, when patients present with chronic pain and sleep difficulties, they tend to have poorer outcomes. So there is more pain severity, longer duration of pain, increased disability, and also they tend to have concurrent mood disorders such as depression, anxiety, and suicidal ideation. So what that tells us is that it's very important to attend to sleep when we are working with our chronic pain patients. Next. Okay, so both chronic pain and sleep disturbances, as we said, are influenced by